Thank you. Good morning. So, my task today to talk about beta blockers. But first of all, I would like to show you a picture of Didier Lebrecq for young people who do not know him. He is still, because he is alive. He's playing golf a lot, but he's retired. And he's the father of non-selective beta blocker therapy in portal hypertension, and I wanted to tell that. Remember, the first paper was a pioneer paper in the Lancet showing that propranolol could be a medical treatment for portal hypertension. Again, in the Lancet, he showed that propranolol in prevention of current gastrointestinal bleeding in a cirrhotic patient was very effective. And this was the beginning of the story. So today I would like to discuss the place of beta blocker, which is well established, which is the prevention of variceal hemorrhage, and then I will discuss areas of controversy on the BB use regarding refractory ascites, decompensated cirrhosis in general, and organ failure. So for the established indication of beta blockers, we have excellent guidelines given by the Baveno group, and the first guideline is to say that in the context of primary prophylaxis, there is no indication to use beta blockers to prevent the formation of varices. Maybe this statement will change in the next years, but we will see. Regarding small varices, patients with red whale marks or Chiapio class C should be treated with non-selective beta blocker, refers to as NSBB. Patients without signs of increased risk may be treated with NSBB to prevent progression of varices and bleeding. Further studies are required to confirm their benefit. Regarding patients with medium to large varices, you can use either NSBB or endoscopic band ligation, referred to as EBL. Traditional NSBB, such as propranolol or nadolol and carvedilol, are valid first-line treatments. Carvedilol is more effective than traditional NSBB in reducing HVPG, but has not been adequately compared head-to-head to traditional NSBB in clinical trials. Therefore, to date, use NSBB. Regarding gastroesophageal varices, there is a single study which suggests that cyanoacrylate injection is more effective than NSBB in preventing first bleeding in patients with large gastroesophageal varices type 2 or isolated gastric varices type 1. Further studies are needed to evaluate the risk to benefit ratio of using cyanoacrylate in this setting before a recommendation can be made. Regarding patients who have a bleeding, I would say that the first-line therapy for all patients in the combination of NSBB, propranolol, or nadolol plus EBL. EBL should not be used as monotherapy unless intolerance, contraindication, or to NSBB. NSBB should be used as monotherapy in patients with cirrhosis who are unable or unwilling to be treated with EBL. Covered tips is the treatment of choice in patients that fail first-line therapy, I mean NSBB plus EBL. Because carvedilol has not been compared to current standard of care, its use cannot be recommended in the prevention of rebleeding. These are the main recommendations for patients who had the first bleed. Now we will reach the area of controversy and regarding patients with refractory ascites. Should we use beta blockers in these patients? This is a true question, and the origin of the controversy came from 3 studies performed by Thomas Aste when he was in our unit. And the first study was an observational prospective study and not retrospective, including 151 patients. Most of these patients, 70%, had diuretic intractable refractory ascites, and the remaining diuretic-resistant ascites. This is the usual profile of our patients with refractory ascites according to Ascites Club criteria, which have been collected prospectively, and this is very important. And 77 of these patients, I mean 51%, were under beta blockers, NSBB. And the main finding of this study is shown here. There was a clear decrease in survival in patients with refractory ascites who were under non-selective beta blockers. However, 2 major criticisms were raised when the paper was published. First, at enrollment, patients on NSBB were a little bit more severe. Second, and probably it is the most important criticism, the Kaplan-Meier, which was used in this study, is probably not appropriate for assessing survival in patients with decompensated cirrhosis who receive, as you know, a liver transplant. And liver transplantation is in fact a competitor for death in this patient. Therefore, we decided to improve our analysis, and we performed a second study using a larger number of patients, 174. 70% had diuretic intractable ascites, 32% had diuretic resistant, 51% had received beta blockers, and we used competing risk analysis to look at the effect on survival. And these are the main results of the study. Here you have the independent predictors of death in this series of patients, and we could confirm that NSBB therapy could be by itself an independent predictor of death. This is very important. So it is totally independent on the severity of underlying liver disease. The other factor was higher Child-Pugh score, and as you can see here, you cannot see MELD score or MELD sodium score among the predictors, and this indicates that these patients are exception to MELD, and therefore this finding indicates that we are dealing with a very homogeneous series of patients with refractory ascites who are an exception to MELD. The other predictors, if we look at diuretic resistant at the control, at the reference, you can see that the risk of death increases when serum sodium is below 125 millimole per liter. And here in this series of patients, serum creatinine was not a clear predictor of death. And this is why probably the MELD score doesn't appear. And also we were interested in seeing that the frequency of large volume paracentesis was an independent predictor of death, probably reflecting some severity of the patients. Therefore, this study clearly shows that treatment with NSBB is an independent predictor for death in these patients. Next, Thomas Este asked the question why NSBB are so deleterious for patients with refractory ascites. And we had in mind the concept of paracentesis-induced circulatory dysfunction. You know that these patients receive large volume paracentesis, at least I would say two per month, 2 sessions per month, and they come very often to the hospital. And we hypothesize that NSBB deleterious effect may be related to PICD. And therefore, we conducted a trial, a crossover trial, in which patients with refractory ascites receiving NSBB were shifted to EBL. And these patients were studied before and after the cessation of NSBB. And this cartoon summarizes the main finding of the study. So we found that it is not a new finding that large volume paracentesis induces arterial hypertension. When patients were receiving NSBB, there was no reflex tachycardia, and there was a huge increase in the activity of the renin-angiotensin system in order to compensate for the lack of tachycardia. In contrast, in patients in whom NSBB were stopped, we observed a reflex tachycardia to arterial hypertension induced by large volume paracentesis, and there was no activation of the renin-angiotensin system. Therefore, the explanation is that the lack of tachycardia and the reflex induction of the system, the renin-angiotensin system, is probably deleterious in these patients, and it is well known that the activation of the renin-angiotensin system is a sign of poor prognosis in patients with cirrhosis. And I think that we can enlarge this, extend these results to the issue of arterial hypotension in patients with cirrhosis. Probably patients who have at rest a low arterial pressure shouldn't receive beta blockers because they don't have the ability to adjust their hemodynamics to any stressful situation. And this is an opinion, and you can see in different international guidelines that low arterial pressure is considered as a contraindication to the use of NSBB, but it is mainly based on the author opinion. But these results give some fuel to this opinion. Okay. I don't know why this. Okay. This slide summarizes the results of other studies which were performed in patients with refractory ascites and looked at mortality. As you can see, there were 3 studies, and they gave conflicting results, different results. The first study by Lighthead showed that beta blockers was associated with an improved survival. But the 2 other studies didn't confirm this result. This is a true example of science which is not very well conducted, because if you look at the study design at the study design of each study, you can see that the nature of this study was either retrospective or was a post-hoc analysis of 3 randomized clinical trials. In addition, if you look carefully to the information in these papers, you can see that the information on the criteria used for the diagnosis of refractory ascites were not pre-specified in the protocol. Therefore, all these results should be interpreted with great caution, and I would say that I would not take into account these results. So in summary for this part, patients with refractory ascites, there is strong evidence of deleterious effect of NSBB therapy independently of the severity of the underlying liver disease. In these patients, starting NSBB is contraindicated. When these patients are already on NSBB, it should be discontinued. Alternative therapies considered. Decreasing NSBB dosage, I would say, should not be recommended because it can result in decreased efficacy for bleeding prevention, and we stop and perform EBL in our unit. What about decompensated cirrhosis outside refractory ascites? We have 5 studies looking at the mortality of these patients with non-refractory ascites, and as you can see, there is a consensus of these studies to say that beta blocker improves survival, except one study, the last one, which was to me not very well conducted. So these studies confirm that NSBB can be used in patients with ascites which is not refractory to treatment. There is another important issue, is the impact of NSBB in patients after first bleeding. This study nicely performed by Juan Albrades some time ago. They look at 8-year outcomes after a first bleeding according to the traditional hemodynamic response to propranolol. And they clearly showed that patients who were non-responders had the lower probability of being free of rebleeding, but also of being free of no ascites recurrence, and also were at higher risk of developing SBP. Therefore, this study clearly showed that when patients respond to NSBB, this could have a beneficial impact on the natural history of cirrhosis. And recently, a group in Austria, Thomas Freiberger and colleagues, showed that non-selective beta blocker therapy decreased intestinal permeability and serum level of LBP and IL-6 in patients with cirrhosis, suggesting that beta blockers could be useful in decreasing bacterial translocation. So NSBB can be used in patients who do not fulfill the criteria for refractory ascites. The last question is, what about patients who have a risk or have developed end organ failures? This is very tough, I would say, very tough, because you have here the study by Mandorfer. On the left side, the results are already showed, beneficial effect of beta blockers in patients before they develop SBP, okay? And then on the right side, you have the Kaplan-Meier estimate of the survival in patients who develop SBP on NSBB. And you can see that there is a reversion of the beneficial effect and clearly a decrease in survival in patients receiving NSBB after they develop SBP. Okay. And in this paper, in addition, they provide an explanation for the deleterious effect of NSBP because they showed that patients on NSBP develop AKI and hepatorenal syndrome, and this was for them an explanation of the deleterious effect of NSBP in these patients who had SBP. Okay, this is one part of the controversy. But next you have another study by Mukherjee who reanalyzed the results of the canonic study, and here you have two groups of patients in this large series of patients, patients with beta blockers light blue and patients without beta blocker dark blue. And on the left of the figure you have the outcome of patients one week after the enrollment, 1 grade reduction of ACLF, 2 grade reduction, 3 grade reduction, and conversely of the right part, you have 1 grade increase and 2 grade increase. And you can see that when you look at reduction of ACLF, the proportion of patients receiving NSBP was significantly higher. Conversely, when ACLF worsened, the proportion of patients who receive NSBP was significantly lower, suggesting that NSBP could have beneficial effect in patients who develop ACLF. And frankly, I have no explanation for this discrepant result between the Mandorfer study and the Mukherjee study, even if I'm one of the multiple co-authors of the Mukherjee paper. I don't know. And I think that the secret maybe should be to perform well-conducted prospective study looking at all these issues. So in summary, there are discrepant results regarding the effects of NSBP on end organ function. The reason for these discrepancies are unclear. Future prospective well-designed studies should be performed. We have to think about which marker to assess NSBP efficacy. Is it still the reduction in heart rate by 25%? Which marker for discontinuing NSBP? Intuitively, I would say decline in blood pressure, but we have to perform studies clearly addressing this point. Is it the increase in serum creatinine? Probably yes. And in conclusion, I'm sorry I'm a little bit too long, there is no or mild controversy on the use of NSBP in the prevention of bleeding. NSBP should not be used in patients with refractory ascites. NSBP can be used in patients with non-refractory ascites. There is still a controversy on the effect of NSBP on end organ function. Thank you for your attention.